So if you'll just make sure that we get it written, you can send it to us, email, carrier pigeon, or you can fly it here on a small piece of paper and give it to our staff here. But thank you for coming today, and we appreciate it very much. I wanted to introduce and thank our Sergeant at Arms. Thank you very much. From the House, we have David Little and Stafford Young. And from the Senate, we have John Boyette, Mike Harris, and Linda Matthews. We could not do what we do in the North Carolina General Assembly if we did not have our Sergeant at Arms. So thank you all very, very much. We appreciate what you do every single day to keep us straight, to keep us safe, and to keep us focused. So we thank you all very much. My hat's off to you. Welcome. This is, I'm not going to spend my usual time praising everybody today. Unlike Potts, he usually praises everybody before you. So, but today we've got a lot on the agenda, and we're just going to move right into our presentations. If you have anything that you want to share with us and you are not, you cannot be recognized today because we only have an hour and 10 minutes. And so we have to stay on that time schedule today. Okay, I will introduce and welcome our Department of Health and Human Services, and thank you all so much for being with us. We've pretty much been together since early breakfast, so we've had a lot of opportunity to talk today. So, Secretary Sangbai.
Great. Thank you, Chairwoman White, and thank you, Committee, for providing this opportunity to talk to you today about how important it is to protect North Carolina Medicaid for the millions of North Carolinians that rely on it for access to health care. Medicaid is one of the most important investments we make as a state. It provides health coverage to more than 3 million people: children, pregnant women, seniors, people with disabilities, and working families. And it is a lifeline for rural hospitals, nursing homes, and the providers who keep communities healthy. What we plan to show you today is that North Carolina has a strong program with systems of integrity in place. We have federal oversight, state audits, internal audits, county reviews, managed care plans, and law enforcement all working together to ensure accountability at every level. Our beneficiary eligibility accuracy is among the best in the nation, with a 0.46% error rate, compared with far higher rates nationally. We verify beneficiary eligibility through extensive electronic data sources, from Social Security to state systems like DMV and DOC. And on the provider side, we use rigorous screening, background checks, site visits for higher-risk providers, and ongoing credentialing. Managed care plans conduct pre- and post-payment reviews, recover overpayments, and serve as the state's front line for monitoring. We have strong systems in place, and we aim to strengthen them. As we talk about protecting the program's integrity, we cannot ignore cost. The rising cost of health care is the primary driver of increasing expense in Medicaid. The biggest pressure on the program comes from rising prices, utilization, behavioral health needs, pharmacy costs, and the overall health of our population. We must keep our focus on what truly makes a difference, helping people stay healthy by getting to the right care in the right amount, at the right time, and in the right setting. When people have access to primary care, when chronic conditions are well managed, when behavioral health needs are addressed early, and when families have access to food and housing supports, we reduce avoidable crises, emergency room visits, and hospitalizations. And that is what sustainably bends the cost curve. We will always maintain strong safeguards and oversight, and we're proud of the results they're delivering. Our strategy has been to balance health, access, and long-term stability, and our decisions need to be backed by evidence, value, and clinical outcomes. Thank you for your time and attention today.
Thank you. And next we have Deputy Secretary Bush. Thank you for being with us today.
Thank you, Madam Chair and members of the committee. Thank you for having me here today. I am going to walk through a lot of information. I'm going to try not to talk too quickly, but I do want to make sure that you have a chance to ask as many questions as you want. As Secretary Sangbai said, we have a very strong program integrity program at North Carolina Medicaid, but we continue to always try to build and improve and strengthen our controls. I'm going to talk about what we do for beneficiary program integrity, what we do for provider program integrity, what our health plans do on our behalf, and then sort of what we are planning to focus on going forward. So as Secretary Sangvi said, more than 3 million people in North Carolina receive health care from the North Carolina Medicaid program. It is a lot of money, and we take fiscal stewardship of this program very seriously. 98% of our expenditures go directly to care, not to admin, not to fraud, not to waste or abuse. And we are very proud of that fact because we believe that it instills trust in our program. When there is no trust in the Medicaid program, then we are at risk that the people who need services from this program will no longer receive them. So we take it very seriously. This is a quick reminder from our last JLOC of the breakdown of the population and our expenditures. You can see that about 80% of our population accounts for less than 50% of our expenditures. 21% of our population accounts for 54% of our spending. And so our program integrity efforts are focused on those high cost areas and high utilization because they can have significant fiscal impact. So I want to take a quick minute to talk about what we mean when we talk about fraud, waste, and abuse. I think you all generally know what we mean by fraud, waste, and abuse, but there are actual federal definitions in law and in North Carolina statute. Fraud means the intentional deception or misrepresentation. It has to have criminal intent, and it is only confirmed by a court decision following a criminal investigation. So the instances of fraud are relatively small compared to the overall instances of waste and abuse. Waste is not defined in federal rules, but it generally is overutilization or inappropriate utilization of services. And then abuse is provider practices that are inconsistent with sound business, fiscal, or medical practice that results in overutilization. So these are important definitions because how we remedy each of these things, it depends on which avenue we're pursuing. We have a lot of state and federal oversight of the Medicaid program. I like to joke, although I do think it's true, that we are the most audited program in state government. We have oversight from the U.S. Department of Health and Human Services, Office of Inspector General, the Centers for Medicaid and Medicare Services, the state auditor, the state internal auditor within the Department of Health and Human Services does preemptive audits, and then looking for our weaknesses, and they share the results of all of those audits with the state auditor. Internally, we have an Office of Compliance and Program Integrity. They do triage for all of the referrals of fraud, waste, and abuse from our health plans and from the public. And then we also have our managed care organizations that all have responsibilities with fraud, waste, and abuse. We also work, it's not on the slide, but I do want to mention that we work very closely with the North Carolina Department of Justice and our Medicaid Investigations Division. So this is what all these layers of oversight look like. You can see all of the entities up top. On the bottom, we do have recurring audits that happen either on an annual basis or on a 3-year cycle. Our state audit, our EGLE audit, and our RETA audits are all annual. And then our payment error rate measurement is a federal audit, and our Medicaid eligibility quality control is a federal audit, and those are on a 3-year cycle. So every year we are undergoing audits of our program for provider enrollment, improper payments, and beneficiary enrollment. These are not optional, unfortunately. And then of course there's the ad hoc audits, but I'm not going to get into that right now. So I'm going to talk about beneficiary program integrity first. What we do on the front end to make sure that the people who are eligible are actually people that are eligible to receive services, and then what we do to make sure that that is happening on the back end. As you all have heard me say before, we have a state supervised, county administered eligibility system. Our counties determine the eligibility, and they also conduct beneficiary fraud investigations. We set the policy, we provide the tools, we do oversight, and we also audit the counties. The North Carolina General Assembly back in 2017 did pass legislation that created an incentive for counties to get eligibility right. General Statute Section 108A-25.1A makes counties financially responsible for any healthcare expenditures that are determined that were given to someone who was erroneously eligible. And so this is a huge incentive for our counties to do eligibility slowly and to do it right, because otherwise they have a financial payback to the state, which we fully recoup. On the front end, we also, you've seen this slide before, we also hit all of our databases that are integrated into our eligibility system. These are federal, these are state databases, Social Security Administration, the Employment Security Office, we get immigration, citizen information. All of these feed directly into our system so that we can primary source verify all information on an application. So once people are in the system, what do we do on the back end to make sure that the eligible people are actually receiving the services appropriately? We have a 3-year recipient eligibility determination audit that is statewide. We do it in 3-year cycles. We have an audit of eligibility by the state auditor. We require our counties to hire certified public accountants to audit their own work every year. And then, like I said, we do have the 2 federal audits on a 3-year cycle that are always looking at eligibility rates. So what have we learned from all of these audits? Our RETA audits are our statewide audits. We have, we test the accuracy of our approvals and then of our denials and terminations. The acceptable threshold, you can see there, is 96.8%. We developed that threshold with the Office of State Auditor. And we've done 2 cycles of these audits because it's been 6 years since they were implemented. In the first cycle, you can see that we got 96% statewide county average. This is across all counties, not individual counties. Hit the threshold of 96% approvals were correct, and 94% of denials and terminations were correct. In cycle 2, you can see that we're still about in the same place. About 96% of approvals were correct, and about 93% of denials were correct. But I will show on the next slide in just a minute how we are showing some continuous improvement. As part of the RETA audit, we do identify those individuals that were erroneously enrolled in the Medicaid program, and we require the counties to pay back medical expenses that were made on behalf of those individuals. So in cycle 1, 75 counties had overpayments for individuals who were ineligible, but it only came to about $101,000, which is very small in the scope of the Medicaid budget. In cycle 2, we found that 65 counties had overpayments in the amount of totaling $208,000. But more importantly, and I think this is probably something that I should lead with more often, is our PERM eligibility error rate at the federal level. This is CMS conducts this audit. They found that in 2003, which was the last time that we had our PERM audit, we have started the PERM cycle in 2006 this year. Our federal improper payment rate due to eligibility errors was 0.46%. And you can see that the national average was 5.95%. And so we are well below the national average in terms of making improper payments due to eligibility errors. And so I think that speaks well for the work that our county DSSs do on our behalf in keeping the right people enrolled. And this is just a quick snapshot. I said, our RETA audit, the big takeaway from this chart is that in our first cycle, we only had 28 counties that met our threshold and 74 counties that did not meet, but we immediately implemented education, technical assistance, training, policy, so that you can see that in cycle 2, 81 counties met our thresholds and only 19 did not. And so we are improving and making positive movement. On the provider side, we also do things on the front end to make sure that we are screening out bad actors. And then on the back end, we conduct numerous audits to make sure that we are paying for the right amount, scope, and duration of services. Our Office of Compliance and Program Integrity is the sort of central triage. We maintain our governance. We triage and refer to the North Carolina Department of Justice. We identify high-risk provider behavior. We carry out administrative actions for waste and abuse. And then we also provide statewide trainings to our MCOs. So on the front end, when providers enroll, they enroll through NC Tracks. North Carolina law requires that they revalidate their enrollment every 5 years. This year, our provider data management platform earned an additional NCQA accreditation because we're actually collecting a lot more information on malpractice history, education, work history, and board certification. And we've set up a multi-payer credentialing committee that reviews provider files. It has representation from all of our plans. All of our health plans have people that are looking for making sure that we have quality providers that are enrolled in the Medicaid program. And just like with our beneficiaries, we do primary source verified information on all applications. We use all of these different databases that you can see listed to the right here. In addition to doing primary source verification of information, we fingerprint high-risk providers. We do on-site visits for moderate and high-risk providers, and we do criminal background checks for every single provider, owner, managing employees. So this is our program integrity, intake, and referral. When it comes into the North Carolina Medicaid program, everything is just sort of a referral. These can come from citizens, they can come from federal and state agencies, our MCOs, providers. We do extensive data analytics and mining to identify trends and outliers, and then we have other whistleblowers. Those come into North Carolina Medicaid program, and our Office of Compliance and Program Integrity does the first level investigation to see if any of these referrals actually include credible evidence of fraud. If we determine that there is credible evidence of fraud, we refer those immediately to the North Carolina Department of Justice Medicaid Investigations Division. And from there, they pursue criminal and civil actions that can result in prosecutions, convictions, settlements, and recoupments. Most of what we see, however, is not criminal fraud. It is generally lumped into waste and abuse. And for those things that come from the managed care agencies, we send them back to the managed care agencies to take actions. And then for fee-for-service, we of course do that. And those actions include technical assistance, we recoup overpayments, we put providers on corrective action plans, and we take the opportunity to tighten up our clinical coverage policies where necessary if we found a gap. In addition to what we do on the beneficiary and provider side, we also have great partners in our health plans. They have more than 150 requirements across their contracts to ensure that fraud, waste, and abuse is limited and that we are all being responsible stakeholders and stewards of our financial dollars. MCOs are required to maintain internal checks, to investigate and report fraud, waste, and abuse, to send referrals, to report and recover overpayments, and join state meetings as appropriate. To do this, they can do internal reviews of providers. They can take administrative actions like education, corrective action plans, or prepayment reviews. They can use data analysis, very sophisticated data analytics in our health plans. They can hold or deny claims when documentation is missing. And then finally, as a last resort, they can remove providers from their network for quality, compliance, or other contract issues. And they work closely with us and with DOJ. So as a result of all of those audits, you can see here 3 different charts that I want to spend a little bit of time on. The first chart you can see is provider fraud, waste, and abuse case complaints. The green part of the bars are cases that have come directly into the department. The blue are referrals that we've actually received from our health plans. Our health plans obviously receive a lot more referrals than we do. They are because most of our managed care plans have most of our population. You can see that there are a lot more referrals coming in, and we keep adding managed care plans to our managed care portfolio, so the number of complaints has increased. Once we get those into our Office of Compliance, we triage them, we see if there's any credible evidence of fraud, and then from there we refer them over to DOJ, the Medicaid Investigations Division. And you can see in each of these years, out of the total number of complaints that we get, we refer a very small number that actually have credible evidence of fraud. And you can see that those numbers have been declining, but that just means that we are getting better at determining and identifying fraud more quickly. And then finally, the Medicaid Investigations Division referral, they accept our referrals, and they have generally for the last couple of years accepted about 50% of the referrals that we send over, and they choose to prosecute those cases in court. So what does this mean for the Medicaid program? What this means is we are trying to weed out the bad actors and recoup the overpayments that we are made erroneously, and we have a number of different ways that we do that. The number one way we do it in the Medicaid fee-for-service program is cost avoidance. It's a lot easier to prevent the dollars from going out than chasing them and recouping them on the back end. And so you can see in the first left-hand chart, the amount that we have avoided over the last couple of years is in the tens of millions, which just means that we have been able to put providers on prepayment review, make sure that they are billing medically appropriate services and preventing those expenditures from happening in the first place. The second chart is our MCO and our Office of Program Integrity overpayments and recoveries. The yellow bars signify overpayments that have been made, and the recoveries are the dark blue. And I do want to caveat here, because I know I'm going to get a question about why are we not recouping everything that we are overpaying. The answer to that is that often many of these providers are unable to pay back the full amount at one time. And so we put them on payment plans. And so they may have 3 years to pay back the amount of overpayment. Unfortunately, another thing that happens is that providers close up shop, go disappear, and we are unable to pursue those payments because they have left the state. But where possible, always where possible, we are working closely with our managed care partners and our vendors to make sure that we are picking up every single penny that we can. And then finally, at the bottom is the number of fraud convictions that we've had over the last couple of years. These are the ones that are credible convictions of fraud, and you can see that the number does fluctuate over the last couple of years. We've obviously gotten very good at identifying fraud and prosecuting it, but it does vary depending. Some of these cases take years to actually go through the entire process, and so it looks like there's a lot of fraud in this fiscal year, but it could be cases that started 3 or 4 years ago. So I just want to caveat that as well. Additionally, program integrity is built into everything that we do at the department. It is built into all of our processes and procedures. We provide education to our providers. A huge tool that we now have for program integrity is electronic visit verification for our home and community-based services. We can get people, we can make sure that the providers are providing the services when they say they are. We've excluded 19 providers from the program this year because they did not meet our requirements. And we've worked with the MID on 40 different provider investigations. We do an annual risk assessment every year of our data mining efforts, and we look at high-cost services and trends that are identified by the MCOs and our oversight entities. Our current year's focus is durable medical equipment, personal care services, behavioral health, and non-emergency medical transportation. And then finally, looking ahead, we plan to use AI to leverage our capabilities to detect fraud, waste, and abuse. We're able to pull cases and schemes from throughout the country to help us do our queries and our data. We're enhancing our edits and audits to prevent questionable claims. We are working closely with the Department of Justice, Medicaid Investigations Division, to enhance our workflow and increase our timeliness. And we continue to be responsive with the Office of State Auditor audits. We are exploring partnership to better coordinate our referrals. And then we also know that our partners at the federal government level, CMS, have told us that there are new tools that will be available to states to help with the fraud, waste, and abuse. And so we are working closely with them and are prepared to implement when those are available. That concludes my presentation. I'm happy to answer any questions.
Thank you very much, Secretary Bush. Senator Sari, you have questions?
Thank you, Madam Chair. Thank you, Interim Deputy Secretary. Maybe we'll remove that soon for the presentation today. I do have a few questions. I appreciate your detailed presentation. One thing off the top, I see that there is a significant, let's see, I think it was on slide 17. Yeah, slide 17. In 2025, there were close to 2,500 complaints of provider fraud, waste, and abuse compared with 1,500 in 2023. That's a significant increase. Do you have any reason to, or I guess, is there any explanation or reason behind this substantial increase over a 2-year period?
In 2023, we actually launched our tailored plans. Was that 23 or 24? 24. In 2024, I can't remember. It's all a blur now. We launched our tailored plans, and so they are also now sending us more referrals for the physical health space too, rather than just the behavioral health space. I think it is really the addition of additional managed care plans that it's increasing the number of complaints that we are able to receive, because they're monitoring their own provider networks and referring it to us as soon as they identify any fraud, waste, and abuse.
Just a follow-up. Thank you, Madam Chair. I've got a 2-part question here, just in a different topic. The prior slide shows that MCOs can remove providers from the network for quality, compliance, or contractual issues. First question, can you walk us through the process that an MCO takes when they suspect that fraud? And then question 2 is, once that fraud is suspected, how quickly can an MCO restrict payment or place a provider on some type of prepayment review?
Thank you, Madam Chair. Thank you for that question. It's a great question. There has been a lot of conversation about this lately. I understand that the plans have the ability to always put providers on prepayment review without consulting with the department. They have the ability to monitor and make sure that they are providing medically necessary services. They can take that action at any time. Often what happens, and this is where it gets a little bit complicated, is, for example, say there is a credible allegation of fraud. We would refer that to the North Carolina Department of Justice, and they may want this provider to continue to bill services so that they can continue to collect evidence. That does cause some frustration, I think, on behalf of the plans, because they can't quickly get rid of that provider, but that would otherwise impede the investigation. They can also put providers on post-payment review, and then eventually, if there's no reason for MID to have us not remove that provider, then they can move towards elimination, terminating contract with that provider for reasons that are outlined in those provider agreements. So it depends, the timeline varies, but it is sometimes slowed down by the fact that we have a credible allegation of fraud, and DOJ requires that the provider continue to bill while they're gathering more evidence.
Senator Bergen.
Thank you, Madam Chairman, and thank you. So talk to me, this whole thing with fraud and the timing. I've talked to the LME MCOs, and I know that one of them has, I think, 43 pending cases with MID right now. And so they've identified what they think is fraud. They've referred it to MID, part of DHHS. It's being reviewed. We're still paying people while it's going on. And, if you look at 2025 on page 18, the amount spent versus the amount recovered in 2025, do we, before we set up a provider, do we check their financial credentials to make sure that if something happens, they are going to be able to pay us back? Do we withhold I would think if somebody's suspected of fraud, we would put them on a limited pay or a partial pay until we figure it out. But how long should that process take? If I feel like somebody is not, if in one of our companies, if I had this, I would cut them off until I figured it out. And I understand about building a case, but it looks like we're losing money building cases. And I'm just trying to get my mind wrapped around this, because we stay after these folks all the time about how they spend money, and we try to hold them accountable. And I think, and I've talked to them at length about some of these things, and I think they're genuinely concerned. And so when they can't get resolution, and I'm not blaming you, I'm blaming the process. But what do we need to do to make that change? Because I can't get, that's a lot of money. I mean, in DHS total dollars, it might not be for any of us individual. If this was coming out of my bank account, I assure you I would address it today. I wouldn't be building a case or anything else. I would stop the bleeding immediately.
Interim Deputy Secretary.
Thank you, Madam
Bush.
Chair. Thank you. Thank you for that question, Senator Bergen. It is a huge topic of conversation, obviously. The plans do have the ability to put those providers on prepayment review, which means that they can review all their claims before they actually pay them. They have the ability to do that at any time, even if they are not allowed to remove them from the network. And so that is one tool that I think there has been some confusion about whether or not that is available to them or not. But it is something that they can use to prevent erroneous billing or overbilling on the front end. I know that the DOJ is, like most state agencies, limited by staff, and the ability to work as many cases as they have is really dependent on the number of staff that they have. So there's the opportunity, if we wanted to increase staffing at DOJ, they could probably process this a lot more quickly. Same with North Carolina Medicaid. We have a triage group internal to North Carolina Medicaid that is limited by the number of staff that we have too, and so that probably slows things down a bit as well. But I will just say that there are other avenues that they can manage the provider while they are still being investigated by the Department of Justice.
Follow up. Okay. Just come back.
Senator Adcock.
Thank you so much. Thank you for the presentation. So as I look at the definitions, and thanks for providing those very clear slide, fraud, waste, and abuse on slide 4 as reference. Go to slide 17, which was what Senator Bergen and Senator Sawyer were both talking about. It seems to me that since it appears that the intent, the outcome's the same, money being spent that shouldn't be spent, but there's certainly a difference in intent between fraud, waste, and abuse. Do you ever stratify those? Because you've got them all put together. And maybe you did, but not for the purposes of this presentation, because it seems to me that the remedies are so different, right? The investigation and the remedy is so different. And I was curious about the providers. I visited some ABA centers in particular, but just as one example of Medicaid. And sometimes, even in other kinds of services, there's a misinterpretation of what the clinical guidelines say versus and terminology there. What the clinician thinks is supervision, as an example, and what that clinical guideline says. Is there a category for inadvertent mistakes? It's not really abuse. I pulled up that statute for abuse. Oh my gosh, a long list of things that clearly are abusive. That's honest error is not included in there. Talk to us about that.
IDS Secretary Bush.
Thank you, Madam Chair. Thank you, Senator Adcock, for that question. So we lump those types of inadvertent errors, or those things that are not intentional, as waste, right? That is waste. That is misunderstanding the policy, and that gives us the opportunity, honestly, to tighten up our clinical coverage policies when we identify that, where we see that, maybe providers misunderstand and they bill 40 hours of a service a week, when we should really be tightening that up to make it more clinically appropriate. We consider those waste. And so in this slide here on slide 18, that really falls into, it could be, if we identify the waste, we could put that provider on prepayment review, and we would cost avoid any erroneous or inadvertent waste and overutilization. And then they also fall into the second chart there of overpayments and recoveries, because the overpayments and recoveries that the department pursues and that our managed care plans pursue are not criminal. Those are the fraud, those are the waste and abuse buckets. And so that's where you will see those too, is those financial overpayments and the amount of recovery. And like I said, we have Many providers that can't pay all at one time, and so it does take some time. But that's sort of how we bucket those. That's the bulk of the complaints that we get. It's not fraud.
I'm sorry, we don't have time. Representative Blackwell?
Thank you, Madam Chair. I don't know if we have time for two, but one
for
at
one.
least to start with, unless we come back.
Unless we come back.
On page 2 of or slide 2, you mentioned supporting rural hospitals. And the introductory phrase talks about health coverage from Medicaid to more than 3 million North Carolinians. Do we not also support urban and suburban hospitals? And I'm curious if you're able to indicate what percentage of the 3 million get some portion of their services from the rural hospitals. I would think that the bulk of Medicaid is at these other hospitals. So why did you just mention rural?
Idea, Secretary Bush.
Thank you, Madam Chair. Thank you, Representative Blackwell, for that question. That's a great question. Yes, of course, lots of Medicaid dollars go to urban and suburban hospital systems and healthcare systems, without a doubt. And that's where the majority of the people, Medicaid beneficiaries, live. I think the reason it's called out here is because Medicaid is the primary funding source for many of our rural hospitals. Many of the people that live in rural areas are enrolled in the Medicaid program, and they're receiving Medicaid support through the Healthcare Access Stabilization Program that we have through our managed care. They're receiving that funding in addition. And so where in a larger, more urban or suburban space, there are lots of different payers, commercial and otherwise. In rural areas, we see that Medicaid tends to be, and I think we heard this morning from First Health, Medicaid tends to be the backbone of their payment system.
Senator Robson.
Thank you, Madam Chair. Just real quickly, would you differentiate for me between financial abuse and then patient abuse? And where is that assessed and captured in terms of the care of patients in those facilities?
Idea, Secretary Bush.
Thank you, Madam Chair. So I'm going to say back to you what I think you're asking, but please correct me, Senator Robinson. So fiscal abuse is what we consider like overutilization of services, overbilling, right? Inappropriate billing practices or inadvertent billing practices. And that could have a potential impact on a beneficiary, absolutely. But when we're talking about fraud, waste, and abuse, when we talk about beneficiaries, we're talking about people who may be enrolled in the Medicaid program that aren't necessarily eligible. Is that the question you're asking, or are you asking a different question?
Well, I'm asking a different one.
Okay.
And I'll get to that later. That's all right.
So you're okay?
Well, yeah.
Well, you can't ask the second question. We don't have time, but I'll come back to you if we
Okay,
have some more time.
okay.
Thank you. Crawford?
Thank you, Madam Chair. Thank you first for the presentation. Appreciate you all being here. You talked about several different types of audits, and I know firsthand about some of those audits, which is great. But can you just go through in a little bit more detail? And I know you have a couple of slides on it on slide 10 and 11. The beneficiary eligibility audit and a little bit about how that process works. And I mean, the results seem very positive for North Carolina, but if you could just go into a little bit more detail about that process and how that works.
Idea, Secretary Bush, if you could summarize it really quickly, we're running out of time. So thank you.
Thank you, Madam Chair, and thank you for that question, Representative Crawford. So we take samples of individuals who are enrolled in the Medicaid program, and we walk through the entire eligibility enrollment process to make sure that every step is followed according to policy. So that's how we determine whether or not someone is ineligible or not. The federal government does the same thing, but on a 3-year cycle. But they essentially take samples of our enrolled beneficiaries and walk through all of the information that they have.
Thank you, Madam Chair, and thank you for being here today. Real quick, if you'll go back to slide 15. Looking there on average, can you tell me about how long it takes from the moment you get a tip on fraud till you recover money? On average, how long does that take?
I don't have that average number, but I can get that for you. It really depends on the details of the case and who's involved and whether it has to go through a fraud conviction or whether it's just waste and abuse.
Thank you.
Thank you so much. Represent our next speaker. If we have time, we will come back because we still have some folks in the queue. But in order to meet the deadline of getting out of here at 2:10, we have to move on. Chief Executive Officer Rob Robinson from Alliance Health. You're on deck. No, you're not on deck. You're at the ball. You're at the pitch.
I'm up. All right, good afternoon, Chairperson White, members of the committee. It's good to be with you. Again, I'm Rob Robinson with Alliance Health, and I'm here with my CEO colleagues, Libby McGraw from Partners, Joy Futrell from Trillium, and Tracy Hayes from Via Health, who will be helping me answer questions. So as you know, we're here to discuss our recommendations to control the rising cost and improve the quality of care for individuals receiving RBBHT, which stands for Research-Based Behavioral Health Therapies, which is a service for youth with autism, typically from 0 to 6. So I know you've heard a lot about autism, so I will try and be clear and concise with a focus on our recommendations. We do have a white paper with more detail on our recommendations, so we'll be sure to get that out to you after the meeting. We have discussed our recommendations with the department, and I want to thank them for their collaboration as we all try to ensure access to needed care in a financially responsible way. We've also either individually or collectively had conversations with our boards, CFACs, providers, standard plans, and other stakeholders like the IDD Council and Autism Society, which all help to inform our recommendations. I know ABA is a bad word these days, and it is unsustainable. I don't think there's any doubt about that. But there are certainly some good things happening with this service. For one, individuals with autism are more than ever getting services that they need. So, of course, that's a good thing. Secondly, we do have some strong providers, some in this room today. I've had the pleasure with meeting with several ABA providers. They clearly know what they're doing. They all want what's best for the people that they serve, and they've actually been helpful in crafting some of our recommendations, and I don't want that to be lost out of the conversation. All right, next slide real quick. Research-based behavioral health therapy is a service for autism. RBBHT is a series of programs or services. One of those programs is called Applied Behavioral Analysis, or ABA. RBBHT is the kind of the umbrella. So for the purpose of this presentation, I'm going to refer to the service as ABA since I can't say RBBHT more than twice. All right, so let me give a little bit of a background on how we got here, right? So there have been some well-intended decisions around this service over the past couple of years to increase access. In July of 2017, ABA was added to the Medicaid state plan. Prior to that, kids could only get this service through EPSDT, early periodic screening, something diagnostic treatment, which said that if children met medical necessity, they get the service even if it wasn't paid for by Medicaid. 2019, the Medicaid increased the number of hours available under the clinical coverage policy. This change came with an increase of 4 hours. In 2021, standard plans launch with open networks to include ABA. At this time, coverage also expanded to individuals over the age of 21. In January of 24, Medicaid increased ABA reimbursement rates by 15%, and then probably the biggest change which impact the financing of this in 2024, Taylor plans launched. At that time, LME MCOs were required to open the network for certain behavioral services and IDD services, including ABA. Also, when we launched, authorization for ABA services was suspended due to Taylor plan flexibilities and Hurricane Helene flexibilities. We were able to reinstitute authorizations in February of 25. So I think all of these changes, again, I think they were well intended, did make the landscape ripe for substantial provider growth and service utilization well beyond what was expected. All right, I know you're running out of time. I think you understand the current trends in North Carolina. Growth is up 347%. Enrollment grew for ABA from almost 4,000 to 13,500. This issue is not unique to North Carolina. I've talked to several health plans across the state. They're all worried about this. It's probably the fastest growing service within most Medicaid budgets across the country. Each state is trying to deal with it differently. I don't know that anyone's got the magic button at this point, but people are continuing to work on this. All right, objectives. So we've established some recommendations with the goal to help ensure financial sustainability and improve the quality of care. Again, our feedback was created based on our experience, information from other states, and conversations with the department, providers, and other stakeholders. All right, we have generally 5 reform priorities. One is to close the network, right? I know this is a big topic. Up until Taylor plans went live, LME MCOs did have a closed network for all behavioral health and IDD services. With the launch of the Taylor plan and subsequently the Taylor plan, the network was open. This move caused substantial growth in the number of providers, particularly for ABA. For Alliance, we went from 30 ABA providers in 2020 to approximately 270 as of today, and the request to have contracts added for ABA continues to grow. So we recommend allowing Taylor plans and standard plans to close this network, which would allow us to ensure only qualified and proven providers participate and give us the chance to monitor access and make changes to maintain timely service for members and families. All right, the next one is enforce and update licensure requirements for facilities providing ABA. ABA was a service that was designed for home and community service delivery. We have found that some providers now run multi-child treatment centers, occasionally without a facility licensed. There is a belief that these facilities should be licensed. So to start, our recommendation is for DHSR to evaluate the licensing requirement and determine if it's appropriate that providers delivering ABA in center-based or group-based settings be licensed. The next, you've already talked about fraud, waste, and abuse. We have certainly seen a growth in fraud, waste, and abuse across the state. For Alliance, in 2020, we had 2 counts of fraud, waste, and abuse. In 2025, we had 21 for the service of ABA. One of the issues, and we've talked about this today, is that plans are required to continue contracting even if the provider is referred to the Medicaid Office of Compliance and Program Integrity, OCPI, for suspected fraud, unless we have approved action to date. To highlight the issue, Alliance currently has 43 cases with MID, awaiting some type of resolution. Again, I understand the process. Our request is either we have to change the process, or as Melanie requested, do we provide more staffing to MID so we can move the needle on some of these providers, because they do get to continue to deliver care. Most oftentimes they continue fraudulent care while they're under investigation, and we just want to stop the bleeding. So it's our recommendations to work with DHS to determine a path that allows the plans to take action against providers after they've been referred to OCPI or MID for potential fraud while the investigation is ongoing. Clarify provider types. Let me go to this one. All right, we have several recommendations for changes to the clinical coverage policy. First recommendation is to set limits on services delivered by telehealth. We found many providers are delivering a substantial amount of ABA services via telehealth, which is not best practice. Telehealth can be a suitable option for certain purposes, but it should not be the standard. So we recommend the clinical coverage policy, which directs how the service should be delivered, that activities be specified in person versus telehealth. Next, require parent and family involvement in treatment. Parent-family involvement is critical to achieve long-term outcome. The treatment plans that we review do not consistently speak to family involvement. This service is not designed to be a babysitting service. So our recommendation is to clarify parent involvement expectations in the clinical coverage policy. Next is to strengthen reauthorization criteria. Again, this is not designed to be a forever service. Reauthorization criteria is very broad, and we recommend strengthening the reauth criteria. Next is ensure staff delivering care are supervised by a qualified individual who resides in North Carolina. Behavioral health techs, the ones actually doing the work, are not consistently certified, and many are overseen by board-certified behavioral health analysts, or BCBAs, who are not always living in North Carolina. We do agree with the department's policy paper that the department should require certification and credentialing of ABA techs as a condition of participation in the Medicaid program. We also recommend that supervisors reside or be licensed in North Carolina. Clarify provider types authorized to diagnose autism and refer to ABA. So there's two things we recommend about the assessment process. One, DHS to clarify who is eligible to provide an autism diagnosis. Secondly, consider a change that prohibits or limits provider self-referral, meaning the provider that provides case management, makes an autism diagnosis, or conducts an assessment may not also deliver autism services to the same individual. This is viewed a conflict. We're finding assessments always typically will read they have autism and they need a lot of hours, right? So we're trying to remove that from the equation. And our last recommendation is to clarify bill for services versus observation and direction. Observation and direction and contacts with individuals and family are part of the current CCP. Observation and direction are not billable, and our recommendation is to make it more clear the differences between observation and what is billable. So in closing, let me say this. So this situation is not unique to the LME MCOs. When we were formed back in 2012/2013, we were asked to come in and control the growth of Medicaid spend on the behavioral health side. At the time, the state was overspent by $500 million, and we did that, right? and we can do that again. What we're asking for is allow us to do the work that we're doing and to work with the department on some policy changes that would give us our full tools to be able to make the change necessary to improve quality and make the finances more sustainable. So thank you.
Thank you. And I'm going to take this moment to just ask one question, and I don't really want it answered because I think your presentation and your summary has answered it already. But my question is, why was it not being done already? Because Policy 8F, ABA assessment, and the CP code 97151 says that all of the stuff that you've gone over should have been in place and being done when we started this program. And I'm going to turn the mic over to Representative Adcock. Senator Adcock.
That's okay. I was representative first. I appreciate that, Madam Chair. So, first of all, I want to commend you and thank you for your presentation. And Mr. Robinson, I really appreciate at the top of it, you said there are good providers who want to do this right and who are doing it right. And I've talked to some of them, and they're actually in favor of these recommendations. The one thing that gives me heartburn or makes me worry is on slide 6. It's number 3, and that is the termination of suspension of providers who are in the ongoing care of children when they're referred for potential fraud while the investigation's ongoing. I can understand the financial aspect of that, but I worry about the children who are current and families currently in care and what happens if their provider is summarily removed from the market. So I would ask 2 things. One, could there not be prepayment review of those providers instead, as one thing to think about, as an alternative to closing them down unless that fraud allegation is so egregious? And alternately, that there at least be a period of transition where that child and family's care can have a warm handoff to another provider and another environment, ABA practice, so that child's care is not just disrupted, but they could actually regress. Because as we know in autism, they become familiar both with and necessarily familiar with their provider of care, but also that environment. So I just think that's something to consider, is the harm that could unintentionally be done by that suspension or termination.
Chief Robinson.
Yep. Thank you, Representative White. Senator, great question. And prepayment review has come up, and we've talked with the department about that. I'll say it this way. Prepayment review is a tool that can be used to help prevent fraud, waste, and abuse. We've done an analysis of it. It is extremely costly and high resource dense program. We looked at a couple of vendors to come in and do it quickly. It would cost us over $6.5 million to do the top 10% of just ABA providers, right? The one reason that we're looking at another path is because you also need the clinical coverage policy to be changed. That needs to be strengthened so that the prepayment review has more meat against the clinical coverage policy. When it's too broad, there's not a lot even prepayment can do. So that's what we want to change.
It's not a question. I just want to be sure you understand. I'm only talking about those providers who've been referred for fraud, waste, and abuse, not all ABA. That's all. I'm looking at that.
Who have been referred for fraud, waste, and abuse? When we refer somebody up to OCPI or MID for suspected fraud, waste, or abuse, we are not allowed to take any action that is related to the fraud, waste, or abuse. If there's something else that we can tackle, we can do that. Prepayment review, for example, is something we would need to do before we ship it up to Medicaid, MID for investigation. Make sense?
Thank you, Madam Chair. I'm probably not one who's qualified to talk about the autism spectrum. I'm a builder. 8 rolls of electrical tape around your finger and you'll be fine. Go back to work. But when I look at your numbers where it went from 660 million to 2.2 billion in autism provider bills, I wonder didn't somebody at some time say, we've got a problem here, Houston, and say, we need to hold off on this? I assume when a provider sends his bill to you, that you pay it or deny it or investigate it. Somewhere, I believe in your conversation, you said you were called in 24 to stop the runaway costs by having managed care. But when it goes up almost 350% in a couple years, somebody's not watching the back door. They taking. I don't see how. I understand autism spectrum. I'm not familiar with it, but I have friends at my age who have grandchildren and children do it. And I know it's a difficult lifelong commitment and a difficult process for the family. But I fail to see how a normal thinking average person would think that you could set a 6-year-old or a 3-year-old or a 10-year-old in front of a computer screen and provide services for him that are effective when we're not sure we know his verbal skills are limited, we're not sure what his actual comprehension is, and think that was a good idea and that it was a good way to provide service. I may be wrong, but I think I know better than that. And anybody can answer that wants to.
Chief Robinson.
Anybody?
Representative Potts, Tracy Hayes with Via Health.
Ms. Hayes, you can speak to Representative Potts.
Thank you. First, I just wanted to clarify that the number that you referenced on that slide, that is a national trend. That is not specific to North Carolina. And we wanted to provide that context to just demonstrate that while we are seeing this huge increase in ABA in North Carolina, it is also happening nationally. So I don't want anyone on this committee to think that that is the number for North Carolina. That is a national number, and that actually came from a very recent Wall Street Journal investigation piece about a month ago, where they came out. I think some of you have seen that article. So I just wanted to clarify that first. This service, autism, the ABA therapy, it is, as Senator Adcock put it is a wonderful service, and it does a lot of good for a lot of families. There have been other services in North Carolina similar to ABA therapy. Some of you will remember a service called Community Support Services that had a very similar trajectory where the clinical coverage policy was not as tight as it could have been. And I think that is one of the fundamental challenges here is when you have a very broad clinical coverage policy, it makes it much harder for the Medicaid program or for any of the managed care plans to effectively monitor the service because the clinical coverage policy is so broad. And so I think that's a big part of it, along with the closed network that Mr. Robinson spoke about. Up until 2024, the tailored plans, when we were LME MCOs operating the 1915 BC waiver, we operated closed networks. So we didn't have all these providers in our networks because we got to decide which providers came into the networks or not. When we launched as tailored plans in July of 2024, the law changed and we had to open our networks for any service that was also in the standard plan service array. And ABA therapy is one of those services that is in both the standard plan contract and the tailored plan contract. So it's an open network service. So the combination of those two things has really been some of the primary drivers to get us here.
Thank you, Ms. Hayes.
Thank you, Madam Chair. Thank you for being here today. Just a comment, observation, and question. So one of the benefits of sitting up here and sitting around the table and watching everybody talk is I get to see facial expressions during the various presentations. And I would be fascinated to hear from DHHS perhaps at some point as a rebuttal to what was said by the LME MCOs. And that, I think that goes to my comment generally is we're spending a lot of time reacting to this issue, and that's really frustrating, seeing the charts and the numbers. And it makes me question, would the LME MCOs, would DHHS have done anything at all about this issue but for us seeing it on the chart a couple months ago, and but for us teeing this up for various oversight committees. That's frustrating to me that we are seeing this exponential growth in this service, and nobody seemed to be asking questions until we started doing so during these oversight committee meetings. Now, my question to the LME, so we've put the fire, I think, on DHHS before. You've given us a lot of recommendations today. You guys are contractual partners with DHHS. You have an obligation to manage costs, to provide outcomes, to administer a program under the tailored plans. You have some responsibility to manage these costs, to make sure that patients are getting the services they need, the services are driving outcome, the outcomes are effective. What can you guys do? What can the LMEs do without us, without DHHS, to manage these costs so that we're not having this? And what are you currently doing? What can you do? And why have you not done it already?
Senator, sorry, are you directing it to one person for an answer?
There are 4 of them. I'll defer it to any and all.
Y'all are all able to answer.
Thank you, Senator. Sorry, I will. That's a great question, right? I can speak for all 4 of us. We're doing a lot to try and curb the cost. This is a 2-part strategy. One is internally, what can we do to better address this issue, and then what are the policy changes that are needed? Internally, we've upped our compliance program. We've used different criteria around utilization management. We've done some more provider education. We're trying to educate our families and our members around the service. The big things, we'll get this fixed if we talked about our recommendations. If we can get a closed network at the clinical coverage policy tightened up, and do something about the fraud, waste, and fraud cases, waste and abuse we're handling, do something with the fraud cases where we can take immediate action, we will get this turned around, and we can do it in fairly short order if all those things fall into place.
Thank you, Mr. Yes, Senator, sorry. You
Follow up. One concrete example of something you've done in the past 12 months to curb these costs. Just one.
We've implemented MSG, and don't get the MSG authorization criteria for this service, and we've already seen an increase in denials.
Thank you.
Thank you, Madam Chair. First, I thank you all so much for being here today, and I think I've had the privilege and pleasure of working with each of you, and I just appreciate the work that you all do. First, a statement, then a question very quickly. I know we're on the clock here. This is very reminiscent to me of what happened with early childhood intervention 20 years ago, where the network was opened and good providers ended up going out of business or having to close up because of the explosion of services or of providers entering that were maybe not providing as quality services. So it is curious to me when we will learn our lesson on those things. But a question I have, just to follow up with Senator Sari. First of all, you know, I appreciate that we're having this conversation. I think that there have been flags that have been raised by various parties, you know, over the course of the past year to 6 months. I also acknowledge that we were having some other challenges around Medicaid through the fall that we're pulling focus on a number of things. But of these reforms that you have suggested, and I appreciate so much you all coming with some options for solutions, what on here are things that the legislature has to intervene on? What are things that DHHS has the power to change without action? And I think that's a little bit of a follow-up to Senator Sari's question around, you know, what can you all do on your own? Where do we need to intervene? What can DHHS do on its own, et cetera?
Mr. Robinson, let's just call you the dream team. So just raise your hand if you're going to speak, Ms. Hayes.
In terms of this list, The first one, closing the network for ABA, that will require an action of the legislature because the enabling legislation for tailored plans and standard plans states that any service that both a standard plan and a tailored plan cover have to be open network. So because ABA is a service that both standard plans and tailored plans cover, the law today is that it must be an open network service. So that would require a change in the law. We believe that items 2 through 5 are all things that we can work collaboratively with DHHS to achieve without involving the legislature.
Thank you, Ms. Hayes. Senator Robinson?
Thank you, Madam Chair, and thank you for taking the time to look at solutions, because we dealt with this at our last meeting and said, my goodness, what in the world happened? But I'd like to know, you mentioned that's a national percentage. What's the percentage of increase in North Carolina, and what percentage of those are local or North Carolina providers?
I'll look at the information that we have on the slide. Is there's been a 347% growth in spending in North Carolina, and there's been an increase in the number of people served from 3,800 to 13,400 in 2025, which is a 250% increase.
Okay, and what percentage are North Carolina providers? Those providers who applied for or requested to be included in the network, how many of those are North Carolina providers?
Senator Robinson, if it's okay, I'll respond. They have to be enrolled with North Carolina Medicaid, but we can go back and get the data. I think you're asking how many of them are out-of-state providers.
Yeah.
We can certainly go back and get that for you.
Okay. One follow-up, Madam Chair.
I've got to go on. I'm sorry. Representative Cunningham?
I thought she said 347 was a national.
Cut us off.
Oh, wow.
I told you they were going to cut us off. Y'all will believe me now.
I got one that's working.
Great. If not, you can come up here. This one's working.
No, that's okay. Let me move over here. Okay, thank you. Thank you for the presentation. Mr. Robinson, you noted that there were 43 cases, fraud, waste, abuse, whatever it is. Do you know what that actual value number is that you're still paying for people that are still actively getting paid? And what, if you were able to recuperate, what that value would be? Because it's going to be two different numbers. And are you taking a loss up under the LME MCO?
Mr. Robinson?
Yeah. Representative Cunningham, it's a good question. I don't have the exact number. Some of these folks have been with MID for just a couple of weeks. Others have been there for months and years, right? And so the overall, those providers get to continue to serve people while they're waiting. And so unless we get to receive permission. So I don't have the overall number of the cost savings or the cost expenditure to the system. But that's a good question. I can see if we take a look at that.
Will you send those to me? Or you can send it to all the committees so we can actually see the numbers. And the last part was that we go up to age of 21 for coverage, and we have about 7,000 children waiting on innovation waiver slots that fall up under autism would be their primary diagnosis. If they turn 18 and they're dual diagnosed, they shift over to Medicare and Medicaid. Is that not correct? If they're dual diagnosed.
Anyone that knows the answer?
Madam Chair.
Yeah, Representative Cunningham, I believe you're referring to dual eligibility for Medicaid and Medicare, and it would depend on the individual specifics of the child. But this service, ABA therapy, can be provided to individuals over the age of 21 under the coverage policy. It is not limited to children currently.
Okay, that's what I was saying. If the child, even if they diagnosed early and then they become eligible for disability after the age of 18, they fall up under Medicare and Medicaid. Whereas if before then they're just falling under Medicaid. That is correct. So that's why I was bringing it up. We serve up until the age of 21. How many other states serve up until the age of 21 if they do have a dual diagnosis? Do we know? Or if all the other states are covering everybody up to age 21?
I don't believe we have that information today, but we can get that for you.
And you can get it to Representative Cunningham, and she'll share it with the rest of us. Representative Blackwell?
Thank you, Madam Chairman. I think I mainly have a comment, and it's sort of a follow-up on Senator Sari and Representative Crawford's comments and questions.
Make it short.
Looking at your ABA reform priorities, you mentioned that 2 through 5 you all would work with the department. I'm surprised you haven't already. On the next page, you've got recommendations for strengthening the clinical coverage policy. Is that a similar thing where DHHS and you guys haven't yet, but you need to talk together? What would be helpful to me would be to get a list from you guys for all these things you're recommending or the priorities, and tell us who's got to do what to enable it to actually occur.
Any response?
I do just want to be clear, we have met with the department several times. We've had very collaborative meetings with Deputy Secretary Melanie Bush. So none of the information that we presented today is something that the department has not seen before. We have shared this with them. The clinical coverage policy requirements, there is a statute in 108A that dictates how, it's called medical coverage policies, how those are modified. So that is not within our responsibility or authority, but the department has the authority to follow that process, which can be a lengthy process.
But nothing prevents you from providing us what you think they ought to do, rather than us bouncing the ball back and forth and say it's on them or it's on us. And why you guys can't do things differently from a process standpoint, I don't understand.
Senator Gailey.
Thank you, Madam Chair. So the LME MCOs, y'all have a big job. You administer the tailored plans, and you work with a lot of North Carolinians who have a lot of different needs. And we've heard about the cost impact of the RB-BHT therapy. I'm wondering, as a different kind of metric to understand the scope of the problem, what percentage of the tailored plan members receive RB-BHT therapy? All the people that you serve, what percentage of them are receiving this kind of therapy?
Anyone, Mr.
Good question. I think we're going to have to get back to you on that.
Senator Bergen.
Well, I have a follow-up, ma'am. Can you tell me what's the average number of hours of service that are delivered every week? Do you know that?
For us, I did ask that question. It's around 24 hours is typically the average, and it varies depending upon the needs, but the mean is around 24 hours.
24 hours over a week.
Correct.
So 4 hours a day.
Correct.
Thank you.
Senator Bergen.
Thank you, Madam Chairman. We did have some providers here last time that said their average was 34 hours. And this is really for all four of you. Can you limit telehealth hours? Can you limit, like, how many, could you say, and I'll throw this out, could you say only 10 hours a week of face-to-face, any more hours the parent has to be involved? Can you do that, or do we need to do something? Could you say, because a lot of folks are telling me they're being told you either sign up for 40 hours or we're not going to provide the services. I mean, this has become childcare to a lot of degree. Can you all do those things? Can you stop out-of-state providers from providing coverage? I mean, I think we have, as I mentioned to some of you, I think we have stocked a pond and everybody's wanting to fish in it. And so just respond to that if you would.
Senator Bergen, for us, part of the reason when you talked about limiting the hours, it goes back to that clinical coverage policy. We can never be more restrictive than what's in the clinical coverage policy, and it's very broad. That's the same thing we run into if we do post-payment or any other kind of reviews. We're not going to win at OAH or anywhere if what we're trying to do is more restrictive than the policy. So I hope that answers part of the question. So we can't limit hours that aren't limited in the policy. We can always be less restrictive, but we can never be more.
Thank you, and we're going to give the last word to Ms. Bush, ISD Secretary Bush.
Thank you, Madam Chair.
You've got 2 minutes.
Yes, I just want to echo what my colleagues here have said. We are working very collaboratively together to change our clinical coverage policy. It is a lengthy process, but we are working and we are hoping to change it as soon as humanly possible because we don't want to be talking about this the next time we come around. So I just wanted to say that there is work happening now, and we know what steps need to be taken. There are some legislative things, though, that do need to happen, like if you were to close the network.
Thank you all for coming. Thank you for being very, very nice. And thank you for asking some really good questions. And I'm sure that we may be getting back together again. Adjourned.